Welcome back to Anatomiqa. In this session, we will be discussing the details of the muscles, vessels, nerves, and clinical anatomy in the back of the leg. At the end of this session, you should be able to describe the superficial, intermediate, and deep group of muscles of back of leg with their attachment, nerve supply, and actions. Describe origin, course, branches, and distribution of tibial nerve. Describe origin, course, branches, and distribution of posterior tibial artery. Describe formation, course, tributaries, and drainage of small saphenous vein. Explain the concept of peripheral heart. Explain the anatomical basis of rupture of calcaneal tendon. The back of the leg is also called as posterior compartment of leg or flexor compartment of leg or the calf. The muscles are bulkiest in this compartment since the muscles function against the gravity. Skin on the back is supplied by the following cutaneous nerves. Posterior femoral cutaneous nerve or posterior cutaneous nerve of thigh pierces the facial roof of popliteal fossa and supplies the upper part of the back of leg. Posterior division of medial cutaneous nerve of thigh supplies the upper part on the medial side of the back of leg. Lateral cutaneous nerve of calf arising from common peroneal supplies upper and lateral part of back of leg. Sural nerve, branch of tibial nerve after joining with sural communicating branch of common peroneal nerve in the middle of the back of leg supplies the lower lateral part of the leg including the lateral side of foot. Posterior branches of saphenous nerve supplies lower part of medial side of back of leg. Calcaneal branch of tibial nerve supplies the posterior surface of calcaneus and weight bearing area of heel. The superficial fascia deep to the skin has following structures. All the cutaneous nerves supplying the overlying skin which have been discussed just now and the small saphenous vein and the lymphatics. The small saphenous vein arises from the lateral part of the dorsal venous arch of the foot. It ascends behind the lateral malleolus along with the sural nerve and enters the back of the leg. It ascends along the lateral border of the tendocalcaneus and then runs in the middle of the back. The vein pierces the deep fascia and passes between the two heads of gastrocnemius muscle in the lower part of the popliteal fossa. It ends in the popliteal vein. The small saphenous vein has numerous valves along its course directing the blood towards popliteal vein against gravity. The tributaries to small saphenous vein are numerous small veins from the back of leg, communicating veins with the deep veins of the foot, important anastomotic branches that run upward and medially and join the great saphenous vein. The mode of termination of the small saphenous vein may vary. It may join the popliteal vein, it may join the great saphenous vein, or it may split into two divisions, one division joining the popliteal and the other joining the great saphenous vein. Lymphatic drainage of the back of leg. Lymph vessels from the skin and superficial fascia on the back of leg pass upward and drain either into the popliteal nodes, or the lymph pass forward around the medial side of the leg to end in the vertical group of superficial inguinal nodes which are situated below the inguinal ligament along the great saphenous vein. Coming to the boundaries of the leg, they are demarcated by the deep fascia and intermuscular septum of the leg. The deep fascia of the leg is very strong and is called crural fascia. It surrounds the leg like a sleeve and is fused with the periosteum where the bones are subcutaneous. Thus, it is attached to the borders of these areas on the tibia, fibula and their malleoli, forming intermuscular septa and retinacula. It is unstretchable. This is very important. The fascia is unstretchable. The intermuscular septa separate various groups of muscles, give attachments to their fibers proximally, and place each group within a tight fascial box. There are three named intermuscular partitions: interosseous membrane extending between the sharp interosseous borders of tibia and fibula, the anterior intermuscular septum, and the posterior intermuscular septum, where one end of them is attached to the fibula. These three septa divide the leg into three compartments. Anterior compartment is present between the lateral surface of tibia and anterior intermuscular septum. The lateral compartment is present between the anterior and posterior intermuscular septa. The posterior compartment is present behind posterior intermuscular septum, fibula, tibia and the interosseous membrane. Now, let us see the boundaries and subdivisions of the back of leg or posterior compartment of leg. Anteriorly, the back of leg is bounded by the posterior surfaces of tibia and fibula and the interosseous membrane present between two bones. Laterally, it is posterior intermuscular septum and posteriorly and medially by the deep fascia of the leg. The posterior compartment is subdivided into three groups of muscles by anterior coronal septum or deep transverse fascial septum and posterior coronal septum or superficial transverse fascial septum. The three groups of muscles are superficial, intermediate and deep groups. The superficial transverse fascial septum is present between the superficial and intermediate group of muscles. Medially, it is attached to medial border of tibia, laterally to the posterior border of fibula, superiorly to the soleal line of tibia and to the fibula beneath the origin of soleus. It is continuous with fascia covering the popliteus muscle superiorly. Inferiorly, on either side of the tendocalcaneus, the fascia blends with the deep fascia of leg. Both the fascia together are continuous with the flexor retinaculum on medial side and superior peroneal retinaculum on the lateral side. The deep transverse fascial septum is attached medially to proximal part of soleal line and vertical ridge on posterior surface of tibia. Laterally, it is attached to medial crest of fibula. The muscles in the posterior compartment, as observed, are surrounded by the deep fascia on all the sides. Hence, when the muscles contract, they are compressed by the fascia so that blood is pumped upwards from them in the veins, which is a very important mechanism of venous return from the lower limb. Extensive division of the fascia or wasting of the muscles within the fascia impairs this venous return and leads to swelling of the limb because of the accumulation of fluid called edema. Contents of back of leg or flexor compartment of leg are superficial group as the following muscles: medial and lateral head of gastrocnemius, plantaris and soleus. The intermediate group is made of popliteus, which is not shown here, flexor digitorum longus, flexor hallucis longus muscles, and posterior tibial and peroneal vessels, and finally tibial nerve. Deep part has only one muscle, tibialis posterior. Coming to the details of the muscles of the back of the leg. Gastrocnemius. Gastrocnemius arises from condyles of femur by two tendinous heads which form the lower half of popliteal fossa. It is a bulky muscle with two heads, medial and lateral head. The lateral head arises from the depressed area on the lateral surface of lateral condyle of femur by a tendon. Occasionally, a sesamoid bone called fibula develops in the tendon of lateral head. It also arises from the groove for origin of popliteus. The medial head arises from the upper and posterior part of medial condyle behind the adductor tubercle and the inferomedial angle of popliteal surface of femur just above the medial condyle. The tendinous origin of medial head is separated from the capsule of knee joint by a bursa. Both the heads run downwards, join with plantaris and soleus to form a common tendon called tendocalcaneus. Through this tendon, all the four muscles are inserted into the middle 1/3 of the posterior surface of calcaneus. Plantaris. It is a vestigial muscle. It arises from the lower 1/3 of lateral supracondylar ridge and adjoining popliteal surface of femur. It is a fusiform muscle with a small muscle belly and long tendon running under cover of lateral head of gastrocnemius. In the lower part of the leg, it runs medial to the tendocalcaneus and blends with it. It is inserted into the middle 1/3 of posterior surface of calcaneus through the tendocalcaneus. Plantar aponeurosis is the degenerated part of plantaris. Soleus. It is a very powerful muscle present deep to gastrocnemius. It is a multipinnate muscle shaped like the sole of foot. The origin is extensive in the form of broad horseshoe. It arises from posterior surface of head of fibula, upper 1/4 of shaft of fibula, soleal line of tibia, middle 1/3 of medial border of tibia, and tendinous arch extending between the two bones behind the neurovascular bundle. The muscle runs downwards and ends in a tendon which fuses with the other three muscles, forms tendocalcaneus and is inserted into the middle 1/3 of posterior surface of calcaneus. Tendocalcaneus is also called Achilles tendon. It is the thickest and strongest tendon in the body. The length of the tendon is 15 centimeters in length. It begins in the middle of calf and receives the muscle fibers from anterior surface till the lower end. It becomes flattened and gets inserted to the middle 1/3 of the posterior surface of calcaneus. It is related to two bursae, calcaneal bursa between calcaneus and tendocalcaneus. This bursa is prone to inflammation in long distance runners. The second bursa is the adventitious bursa located between the tendocalcaneus and the skin. We have seen the superficial muscles of back of leg one by one. Now let us see how they are arranged and related to each other. From superficial to deep, the muscles arranged are medial and lateral head of gastrocnemius, which are present in the same plane. Deep to it is the tendon of plantaris and then soleus. Nerves applied to the superficial muscles are all the four superficial muscles, medial and lateral head of gastrocnemiae, plantaris and soleus, are supplied by the branches of the tibial nerve. Coming to the actions, the gastrocnemius and soleus muscles cause plantar flexion of the foot at the ankle joint. Medial and lateral gastrocnemiae bring about flexion of the knee joint. In flexed position of knee, the gastrocnemius cannot act on the ankle joint because it is acting on the knee joint. So soleus alone brings about plantar flexion when the knee is in flexed position. Plantaris acts as accessory muscle in flexion of knee and flexion of ankle joint. Both gastrocnemiae and soleus together provide the main propulsive force in walking and running. Gastrocnemius is more active in these actions. The gastrocnemiae muscles are examples of white muscle. Soleus, apart from plantar flexing the ankle, is also the postural muscle and is an example of red muscle. For the details of white and red muscles, please check the video on muscular system. In this video, you can observe the flexion of the knee and the plantar flexion of the foot. In the plantar flexion of foot, the heel of the foot is raising at the back of foot and the toes are directed downwards towards the ground. Both the muscles, gastrocnemius and soleus, together make the calf muscle pump. This facilitates the venous return from the lower limb. There are large venous sinuses present in the soleus, which connects the superficial veins and the deep veins. So, when the soleus contracts, it helps in sucking the blood from superficial veins to the venous sinuses or perforating veins and propelling it towards the deep veins, and from there the blood is pushed towards the heart against gravity. Because of this function, soleus is mainly called the peripheral heart of the lower limb. Testing function of gastrocnemius. The patient is asked to extend the knee and then plantar flex the foot against the resistance. Contraction of gastrocnemius should be felt if it is normally functioning. The second method to test the gastrocnemiae are: the patient is asked to stand on his toes, supporting his hands closely on the wall, which is placed loosely on the wall. The two muscles become tight due to their contraction which shows that the muscles are normal and functioning. Test in function of soleus. The patient is asked to flex the knee and then plantar flex the foot against resistance. If the patient can plantar flex the foot against resistance, the soleus muscle is normal. The second method to test the soleus is the patient is asked to flex the knee and stand on his toes, supporting his hands loosely on the wall. The muscle becomes tight due to its contraction, which shows that the soleus is normal and functioning. Popliteus. This muscle forms the lower part of floor of the popliteal fossa and is important in unlocking the knee joint. The muscle takes its origin from the anterior end of popliteal groove on the lateral surface of the lateral condyle of femur. Its origin is tendinous and is located inside the capsule of the knee joint. Hence, this part of the tendon is called intracapsular tendon. The intracapsular tendon runs between the lateral ligament of the knee joint and the lateral meniscus, separating the two structures. The meniscus is not tethered to the ligament and is freer to move and adapt to the surfaces of the condyle of the femur and the tibia. The long tendon is enclosed in synovial sheath, pierces the posterior part of the fibrous capsule below the arcuate popliteal ligament and emerges out of the knee joint. Here it expands in a triangular fleshy belly which is inserted into the posterior surface of the tibia above the soleal line. Important events occurring at the lower border or the distal margin of popliteus are: the popliteal artery terminates into anterior and posterior tibial arteries. The popliteal vein is formed by the union of anterior and posterior tibial veins, which are nothing but the venae committantes respective to the arteries. The tibial nerve enters the posterior compartment of leg. The nerve to popliteus winds around the distal margin and supplies the muscle from anterior surface. The nerve to popliteus, a branch from tibial nerve, apart from supplying popliteus, also supplies the following structures: interosseous membrane of leg, proximal tibiofibular joint, distal tibiofibular joint, and tibialis posterior. The actions of popliteus are: it is a key muscle in unlocking the knee joint during flexion in a fully extended position of a knee. In the beginning of flexion of a fully extended or locked knee joint, the popliteus either rotates the tibia or the femur depending on the movement of leg. For example, in squatting, the femur is moving and tibia is stable on the ground. In walking, the tibia is moving and femur is stable. So what happens in the initial 30 degrees of movement is, in squatting, the femur is rotated laterally on the tibia, which is stable, unlocking the extended knee by the popliteus. During walking, the tibia is rotated medially on the femur when the foot is lifted off the ground. This is known as unlocking of knee joint. It protects the lateral meniscus from the injury. Flexor digitorum longus. It has a course in the leg and in the sole, changes direction and acts on many joints. It takes origin from the medial part of posterior surface of tibia below soleal line, medial to origin of tibialis posterior. The muscle fibers of flexor digitorum longus runs downwards on medial side of the leg and in the lower part forms the tendon. The tendon of tibialis posterior superficially is crossed by the tendon of flexor digitorum longus in the lower part. At the ankle, it passes deep to the flexor retinaculum and then enters the sole. In the sole, the tendon turns laterally and crosses the tendon of flexor hallucis longus superficially. While crossing, it receives some fibers from the flexor hallucis longus called as William-Turner slip. The tendon now splits into 4 digital tendons for lateral 4 toes. Each digital tendon gives origin to lumbrical muscle of the foot. It also receives the insertion of flexor digitorum accessorius from the lateral side, which straightens the pull of action on the toes. It enters the fibrous flexor sheath, pierces the tendon of flexor digitorum brevis, and is inserted to the plantar surface of the base of terminal phalanx of lateral 4 toes. Nerve supply and actions of flexor digitorum longus. It is supplied by the tibial nerve. It brings about plantar flexion of the lateral 4 toes at metatarsophalangeal joints and both interphalangeal joints. It helps in plantar flexion at ankle joint and provides support to the arches of foot. Here you are observing how the tendon of flexor digitorum longus is entering the sole, splitting into 4 tendons and getting inserted to the distal phalanges of the lateral 4 toes. In its course, also observe how it is crossing the tendons of tibialis posterior near the ankle and the flexor hallucis longus in the sole. Flexor hallucis longus. It arises from many points. The lower 2/3 posterior surface of shaft of fibula behind medial crest below the origin of soleus. Interosseous membrane below the tibialis posterior, from the fascia covering the tibialis posterior and the posterior intermuscular septum. The muscle fibers run downwards and in the lower part of the leg it forms the tendon which passes obliquely downward and medially. In its course, it lies in a groove on the lower end of tibia. It also grooves the posterior surface of talus, then grooves the sustentaculum tali of calcaneus and passing deep to flexor retinaculum enters the sole. In the sole, it crosses the tendon of flexor digitorum longus in the second layer of sole and gives fibers to the flexor digitorum longus tendon called William-Turner slip. Then it is inserted into the base of the distal phalanx of the great toe. The tibial nerve supplies the muscle, flexor hallucis longus, The muscles bring about plantar flexion at the ankle joint and plantar flexion of great toe. It also supports the medial longitudinal arch of the foot. Tibialis posterior. It is the deepest muscle of the back of leg, which is overlapped by the flexor digitorum longus and flexor hallucis longus muscles. It arises from the upper 2/3 of the posterior surface of the interosseous membrane and adjacent parts of the posterior surface of the tibia and fibula, that is, lateral part of posterior surface of shaft of tibia below the soleal line and upper 2/3 of posterior surface of the shaft of fibula. The muscle fibers are directed downwards and the tendon in the lower part of leg passes deep to the tendon of the flexor digitorum longus. Then, in the groove behind the medial malleolus enclosed in the synovial sheath, passes deep to the flexor retinaculum and enters the sole. In the sole, the tendon of tibialis posterior runs superficial to the spring ligament. The tendon inserts on plantar surfaces of all the tarsal bones except the talus and to the bases of the middle 3 metatarsals, that is the 2nd, 3rd and 4th metatarsal bones. It is supplied by the tibial nerve and the nerve to popliteus. It is the chief inverter of the foot. Inversion is the movement of foot where the medial border of foot is raised. It is a weak plantar flexor of the foot at the ankle. It gives the main support to the medial longitudinal arch. Now let us see the attachments of flexor retinaculum and the arrangements of the structures passing deep to it. Flexor retinaculum is attached anteriorly to the posterior border and tip of the medial malleolus. Posteriorly and laterally, it is attached to the medial tubercle of calcaneum. On the deep surface, it is related from medial to lateral side to the following structures. Tendons of tibialis posterior, flexor digitorum longus, posterior tibial artery, tibial nerve and tendon of flexor hallucis longus. The mnemonic to remember the structures passing deep to flexor retinaculum is: postal departments are never honest. P stands for tibialis posterior, D for flexor digitorum longus, A for artery, N for nerve and H for flexor hallucis longus. Artery of the back of leg is the posterior tibial artery. Popliteal artery terminates at the lower border of popliteus muscle and divides into two terminal branches, anterior tibial, which enters the anterior compartment of leg, and posterior tibial artery, which runs in the posterior compartment of leg. The posterior tibial artery, which begins at the level of the lower border of the popliteus muscle, enters the back of leg anterior to or deep to the tendinous arch of soleus. In the back of leg, it then passes downwards towards the ankle joint and in its course, superficially, it is related to the following structures: the deep transverse facial septum or deep transverse fascia of the leg, the soleus and the gastrocnemius. In the lower part of the leg, the artery is covered only by skin and fascia. Anteriorly on the deep side, it lies on posterior surface of tibialis posterior muscle above and on the posterior surface of the tibia below. The artery passes behind the medial malleolus and deep to the flexor retinaculum and abductor hallucis, where it terminates by dividing into medial plantar artery and lateral plantar artery. The relation of the artery to the tibial nerve varies in different parts of the leg. The nerve is related medial to the artery in the upper part, crosses the artery posteriorly and in the lower part lies posterolateral to the artery. Posterior tibial artery in its course gives rise to several branches. Peroneal artery is a large artery that arises close to the origin of the posterior tibial artery. It descends close to the medial crest of fibula, either within the substance of the flexor hallucis longus muscle or anterior to it. The peroneal artery gives off numerous muscular branches, a nutrient artery to the fibula, communicating branch which communicates with branch from posterior tibial artery, perforating branch pierces the interosseous membrane to reach the lower part of front of the leg and ends as calcaneal branch by taking part in the anastomosis around the ankle joint. The other branches of posterior tibial artery are through the course of the artery. Muscular branches are distributed to muscles in the posterior compartment of the leg, nutrient artery to the tibia, circumflex fibular artery which winds round neck of fibula and takes part in genicular anastomosis, communicating branch which joins the branch of peroneal artery, medial malleolar branch takes part in medial malleolar network, medial calcaneal branch supplies skin of the heel, and the terminal branches medial and lateral plantar arteries. Coming to the surface marking, the first point should be marked at the level of neck of fibula in the midline on the back of leg. The second point should be marked midway between the tendocalcaneus and medial malleolus. Join these 2 points which represent the posterior tibial artery. Posterior tibial veins. Venae committantes of the posterior tibial artery are called the posterior tibial veins. Venae committantes are a pair of veins always accompanying any of the deep arteries in the body. The veins accompanying the lateral and medial plantar arteries called lateral and medial plantar veins respectively join deep to flexor retinaculum to form posterior tibial veins. The posterior tibial veins ascend along the posterior tibial artery to the lower margin of popliteus muscle, where they terminate by joining with the venae committantes of the anterior tibial artery in the popliteal fossa to form the popliteal vein. It receives the tributaries from the muscles, venous plexus in the soleus, peroneal veins, perforating veins which connects the greater saphenous vein, having unidirectional valves. The blood flows always from superficial to deep veins. Tibial nerve. The tibial nerve is the larger terminal branch of the sciatic nerve arising in the lower third of the back of the thigh. It descends through the popliteal fossa, enters the back of leg deep to the tendinous arch of origin of soleus along with posterior tibial vessels. In the leg, it is related superficially to the soleus and the gastrocnemius muscles. On the deep aspect, anteriorly, it lies on the popliteus tibialis posterior and lower down the leg on the posterior surface of the tibia. The nerve accompanies the posterior tibial artery through its course. At first, the nerve lies on the medial side of the posterior tibial artery, then crosses posterior to it, and finally comes to lie on the lateral side of the artery. The nerve with the artery passes behind the medial malleolus between the tendons of the flexor digitorum longus and the flexor hallucis longus. It is covered here by the flexor retinaculum and terminates by dividing into the medial and lateral plantar nerves. Branches in the leg below the popliteal fossa. Muscular branches to the soleus, flexor digitorum longus, flexor hallucis longus and tibialis posterior. Articular branch to the ankle joint. Cutaneous branch, that is the medial calcaneal branch, supplies the skin over the medial surface of the heel. Terminal branches, medial and lateral plantar nerves, which supplies the structures in the sole. The next few slides shows the tabular column of the muscles of back of leg in a summary form. You can please pause the video and go through them. Now coming to the clinical anatomy, let us look into some of the clinical aspects. Deep vein thrombosis and long distance air travel. Deep veins of the leg are very important since they are prone to thrombosis. In the people where the lower limb is immobilized for a long time, like plaster cast or post-operative period, or in the passengers who sit immobile for long hours in flights, are very prone to deep vein thrombosis in the legs. Thrombosis of the veins of the soleus muscle give rise to mild pain or tightness in the calf and muscle calf tenderness. In some cases, deep vein thrombosis can also occur with no signs or symptoms. If the thrombus becomes dislodged, it passes rapidly to the heart and lungs, causing pulmonary embolism, which is often fatal. Preventive measures include stretching of the legs every hour to improve the venous circulation. Gastrocnemius and soleus muscle tears or tennis leg. Tearing of gastrocnemius or soleus muscles will produce severe localized pain over the damaged muscle. Swelling may be present. Ruptured tendocalcaneus. Rupture of the tendocalcaneus is common in middle-aged men and frequently occurs in tennis players. The rupture occurs at its narrowest part about 2 inches or 5 centimeters above its insertion. A sudden sharp pain will be felt by the person with immediate disability to plantar flex the ankle joint. The gastrocnemius and soleus muscles retract proximally, leaving a palpable gap in the tendon. Plantar flexion is lost and it is impossible for the patient to plantar flex the foot. The treatment is the tendon should be sutured as soon as possible. The leg should be immobilized with the ankle joint plantar flexed and the knee joint flexed. The fascia lata can be used to suture the tendon. Plantaris tendon and autografts. The tendon of plantaris muscle can be used for tendon autografts in repairing ruptured flexor tendons to the fingers. The tendon of the palmaris longus muscle can also be used for this purpose. Tibial nerve injury. It is very rare. If injured, it shows following effects. The deep muscles of the back of leg and sole are paralyzed. There is loss of sensation on the sole, consequently leading to the trophic ulcers on the sole. Tarsal tunnel syndrome. In this condition, the tibial nerve is compressed in the osseofibrous tunnel deep to flexor retinaculum. The symptoms are burning, tingling and pain in the sole of foot. The treatment is surgical division of flexor retinaculum, which relieves the severe and persistent pain. With this, we complete the topic on back of leg. Thank you for listening till the end. If you found the video useful, like and share in your contacts and friends. If you have not yet subscribed, please subscribe to the channel.